S.R. Arvind, it's really a great pleasure and an honor for me to introduce Dr. S.R. Arvind, who's a director and a chief diabetologist, Diacon Hospital, Bangalore, and is a course director for PG students of Health University, RGUHS and RSSDI. He was president of RSSDI during 2015 and 2016, and he was also president Diabetes India, and has got over 100 papers, has conducted over 100 phase 2 and 3 clinical trials. So he's a endocrinologist of great repute and a great diabetologist and he is a leader of RSSDI. So over to you, Dr. S.R. Arvind.
Before I request, yes, for a, so I request Dr. Vasant Kumar and Dr. K.K. Parikh to digitally hand over this citation to my great friend and President of Diabetes India, Dr. Aravind. So over to Dr. Aravind. But before that, I will request Dr. Vasant Kumar to say a few words for Dr. S.R. Aravind.
Thank you, Dr. Bansi. It's wonderful to be in this very important session where we are remembering a legendary figure, Dr. Suman Shah, and sharing the dais with my senior colleague, Dr. Parikh, and of course, going to listen to my close friend, Dr. Aravind, a very prolific writer, speaker, researcher, and whatnot. He has already been introduced by my colleague. Dr. Aravind, we are very eagerly waiting to listen to this oration. Over to you.
Thank you.
Thank you. Thank you so very much. And I will be sharing the screen. Thank you so very much. I think at the outset, I would like to thank Banshi and of course his whole team and Mrs. Banshi Sabu. We've been good friends for many years. We've been working in associations together for almost 2 decades now. It's always a pleasure. The topic of my day today is, of course, the clinical inertia, and I hope Banshi had no inertia and his team had no inertia in choosing me to give this Sumant Shah oration. Well, I had absolutely no inertia in accepting this particular honor, and thank you so very much, Dr. Banshi, for this very, very great offering that you have done to me to give this Sumant Shah oration. Thank you so very much, Vasant. Thank you so very much, Dr. Parikh. Thanks, Vipul, for saying a few good words. It was great listening to Dr. Premal Thakur, who spoke about Sumant Shah. Well, personally, I haven't met him, but I hope I will do justice to his oration today. Well, it's always told that when you start an oration that your initial sentence of words have to be very powerful and also it has to be funny. Well, I tried to do that, but unfortunately I got married when I was 26. So the word powerful has been taken away by my wife. Well, not so funny nowadays, but I still see my friend Banshi managing to be full of energy, and we haven't met in person for quite some time. I hope this COVID will go away and then we'll start having some meetings which are going to be physical. So on a serious note, I think clinical inertia is something that we all have to worry about. Well, people have been talking about a number of things as to why the clinical inertia is there. It can be patient related, it can be physician related, it can be healthcare system related. So I will take a slightly different tone today. What is clinical inertia? Well, it's a failure of clinicians to intensify therapy when clinically indicated. Well, this has been termed as inertia. Well, every time something goes wrong, I know the clinicians are blamed. It's rather unfortunate because the mistakes are not always ours. And who all play a role? Let's look at this. Well, I accept that we as clinicians play a role in inertia. Well, patients have a role too. The entire health system has to be blamed for this clinical inertia. And of course, in India especially, it's the insurance and payers, and same is the fact with the rest of the world and specifically in USA. Well, the producers of medication, the pharma industry, has a big role to play in this clinical inertia. I blame them too. When they blame us, we blame them too. And the producers of devices and the lack of government initiatives. I think there's a huge group of people who are a part of this clinical inertia. And all the above players can help to reduce inertia, which is often blamed on the doctors and patients. So I will try to concentrate on a few things today. And of course, I will not be talking about definitely the inertia being played by the pharma industry, the producers of devices, and of course, our government initiatives. That's for another day altogether. Look at a patient with diabetes today. Well, he's going to be taken care of by a diabetes specialist. You need a dietitian, you need a nurse educator, you need a podiatrist, you need an ophthalmologist, you need a psychologist. On the other side, you need to equip your hospital with the biochemistry and hormones lab, then radiology, the cardiac workup lab, the pharmacy, the research setup, the diet kitchen, cafeteria. If that isn't enough, then you also need to have cardiologists, neurologists, nephrologists, and andrologists. So diabetes management today, my dear friends, is multidisciplinary and involves a lot of teamwork. And this has a lot to play in the inertia. And as I go on, you will understand why it's becoming difficult for each one of us to practice this discipline. It's extremely difficult for a doctor who is clinic-based to do all the things that I just spoke of. And that's where the problem is. Can I do all these days? It's completely gone. Just look at this particular slide, which I used 2-3 years back at the ATTD conference. You have 8,760 hours in a year, and only 1 hour is spent by the physician with the person with diabetes every year. And this is the reality. And sometimes it's even less. I have seen it happening in places like CMC Vellore, where the consultant has just about a minute or two to write the prescription. He has no more than that. So we are all at best able to provide a very episodic care for a continuous disease like type 2 diabetes. And there is an epidemic of diabetes happening. And we have limited doctors. We have to accept non-availability of medical and paramedical infrastructure. We have to accept severe lack of trained doctors, especially beyond tier 2 or tier 3 cities. Limited access to high quality standardized primary care. And all these changes basically result in suboptimal clinical outcomes and high rates of complications. And that's blamed as inertia. Well, all of us have to take the blame because we do live in a country called India, and we have challenges and we have problems. And there's a very high out-of-pocket cost for patients. So diabetes care is a teamwork, and we have to accept it if we have to practice diabetes. Dr. Venkatram very clearly told us that diabetes from the day one is a cardiovascular disease. Well, it's not just that. It's turning out to be cardiometabolic, renal, and vascular in approach. There are talks going on in US to start a specialty to have all these things churned in after you graduate in your MD medicine. There are mysteries of diabetes, and these are very, very sweet mysteries. A number of things are still not very clear. The mysteries of diabetes is evolving, and it will continue to evolve. And a continuous knowledge and the update of this knowledge through CMEs, I think, is a must. I will not be incorrect if I say that the knowledge gained from MBBS or MD or DM today may end with just thermometer reading tomorrow, because what I realize is 32 years back, I got trained in diabetology. I was trained under Professor Vishwanathan, Dr. Mohan's father, highly grateful to the team. But what I read in those days and what we are reading today has totally changed. But of course, as Dr. Premal Thakur said, and as Dr. Venkatram said, it's the discipline and the patience and the compassion that we learned when we were there as students. So every doctor must realize that what we are learning about diabetes today is going to change. So we have to become humble, because our inertia to better care for diabetes can start with the knowledge that, oh, we know everything. No, we don't know anything about diabetes. So we have to optimize diabetes care to avoid therapeutic inertia. It's a big cascade of events that's happening. It's not about working harder, it's about working better with discipline and probably a lot of patience, because day in and day out, I and you do the same thing. There is no diagnostic challenge in diabetes. It's the routine work that we do every day. Keep talking the same things over and over again. So we may lose the patience and the discipline. And we have to be passionate, we have to be motivated. So what I would like to tell today is, if you would like to overcome this inertia, the first thing that you need to do is evaluate your practice pattern. What is your practice pattern? Are you going to have a hospital like All India Institute, or are you going to have a setup like what Dr. Mohan has, or what someone else has? Do you want a comprehensive care hospital dedicated to diabetes? What is it? So I think that is the first step. Everyone can't be what Dr. Banchi Sabu is, or Dr. Mohan is, or anyone else can be. So first, evaluate your practice pattern. Evaluate the patient segment that you can cater to. Highly educated class? Is it the middle class? Is it the high class? What is the segment? And you need to take time to develop a system to tackle inertia in your practice. If you don't deal with inertia, I think inertia will deal with you. Let's understand the economic menace of diabetes in India. I'll quickly go through some of these slides. 2016, you need about 25,000 rupees if you just have diabetes. That's per year to manage diabetes. With complications, it's going to increase. And this is a slide from St. John's, Bangalore, way back in 2017, who said that apart from diabetes, if you need dialysis, this is the kind of a cost that you are looking at, another 25,000 rupees a year, which is a lot of money. And this is from our good friend, Dr. Shashank, who wrote about diabetes care in India, which was a review article. And he very clearly wrote that considering the high cost incurred at various steps of screening, diagnosis, monitoring, and management, it's important to realize the cost-effective measures of diabetes care that are necessary to be implemented. So it's not just about writing the drug. You can be perfect in writing a prescription, the right insulin, the right tablets, but it's about also screening, diagnosis, monitoring, management, and the cost is getting added up. Let's look at the therapeutic advances over past 20 years. Well, we all know this. And as the therapeutic advances happened, the standards of care starting from 1989 by ADA started coming. They started telling us, based on the evidence you use this, based on the experience you don't have to use, but go by evidence-based medicine. So we started looking into evidence-based medicine. What's happened in the last 20 years is something that you have to see now. Despite increasing number of new diabetes medications and technology, achievement of individual targets declined from almost 70% to 60%. Well, this is something extremely sad, and this is happening all over the world, not just in India. And these are slides taken from the ADA. These are the US slides. It's very, very sad that nothing has happened in 20 years in spite of increasing number of new medications and technologies. Let's see what has happened to percentage of patients who are not under control, despite increasing the number of new again medications and technology. HbA1c more than 9 increased from 12.6 to 15.5 all over the world, not just in India. So I don't think we have to just blame ourselves as doctors. There is more to inertia than just the doctors playing a part in this entire drama called diabetes. Now, in spite of advances in health technology, drug therapies, and policies, it has not translated to improvements in diabetes care quality. It has remained exactly the same. And this is directly from ADA. Now, what's wrong with this diabetes picture? Let's ask a question. Decline in percentage of patients at HbA1c less than 7, not even 20% in India. At best, only 50% of patients at goal, just a guess. Increase in percentage of patients with very poor control, unacceptable levels of morbidity, mortality, and diabetes-related cost to society are tremendous. And all this despite more than 40 new type 2 diabetic treatment options approved since 2005. In spite of knowing this, whenever you read an article about inertia, it's always the physician who is getting blamed. Or when a physician is asked a question, why your patient is not doing well, the physician blames the patient for not following these things. So it's a blame game that's been happening. And the root problem is there is inertia both at the patient's level, at the doctor's level, at the industry's level, at the government level, at the insurance level, etc. So we can talk about dyslipidemia, legacy, and how the complications increase and how we are taking time. But all these are playing a big role in the inertia. So look at the therapeutic inertia, rationale, and clinical relevance. It's a failure to establish appropriate targets and escalate treatment to achieve treatment goals. Fine. We are responsible for substantial preventable complications of diabetes with the associated excess in both direct and indirect healthcare costs. And always this slide is shown. Step ladder does not work. You have more number of guidelines. You don't have to really wait. Don't start on 1, then go to 2, then go to 3. All this is fine. Now we know that day 1, you can start with 2 drugs or you can even start with 3 drugs. Still, we are unable to start insulin. There is inertia on both sides when we have to start insulin. It's not that we don't know. With so many CMEs, the doctors are aware of starting insulin. At least a good number of doctors. There are barriers to insulin. I can list another 10 points over here, and all of you are very familiar with this particular thing. I think basically both the patient and the doctors have to take the blame. And then the ADA comes out and says, don't have inertia to start insulin, start your basal insulin. I know everybody is doing their job. The industry is doing the job. They say basal insulin is easy to start. You can start with 10 units. You can increase the dosage. I agree that it has become easier to initiate insulin with the basal insulin, especially the analog basals like Glargine and others, which works for 24 hours. But still there are challenges. We have limited resources. There is a delay in starting insulin. There is limited accessibility to all types of insulin across India. So we can talk about physician barriers. And we have been speaking about a physician barrier all along. But every physician goes through this problem. It is not just the knowledge. One of the things, of course, I agree is physicians need to spend a little more time which they are not spending. And there are some barriers in physicians' mind to start insulin. Well, the patient's resistance. Nobody likes insulin. Nobody likes an injection. Even the best of your patient you have to convince. Then the physician's inertia, I'm too busy, no time to teach a patient and family. That's because he has 20 other patients waiting. He does not have a system. He has not built his team. And the need for intensive monitoring during the initial phase of insulin initiation, well, I have no time. The doctor is worried about hypoglycemia. He will say the patients will call me in the middle of the night and eat my head. So I don't want to go through that. Well, he will give excuses of weight gain with insulin, which is not good for the patient. Then finally, some always accept, well, I know everything, but don't have a team to educate. That's why diabetes practice today is not as easy as we think it is. It needs a team. And these are the patient barriers. I will not go into the details of the patient barriers, and all of us have experienced this. Everybody hates to take an insulin shot, whether you call it a needle phobia or the cost or lack of education, or they think that it is the last stages or developing insulin dependence, whatever it is, there is going to be resistance. I think the important thing from the doctor's side to come out of this inertia is the brief consultations now must change. If you have to start insulin, you have to have time. Unavailability of insulin, yes, it's slowly going away. Cold chain has improved. So we have insulin, the best of insulin, almost in most of the villages even today. Few specialists, well, you don't really need a specialist, either a physician. Every general practitioner can learn to treat diabetes, and that's the need of the hour. And we have to do it. But what I agree is that the tremendous shortage of diabetes educators, nurses, and diabetes care teams to provide the patient support. Pharma tried to do its best, but it has never worked because the people who sit behind those telephone lines and talk to the patients are not really experts. And that's where the problem is. A typical situation, this lady patient is being seen by this doctor, and she's thinking I should accept insulin to protect my future, but she's also thinking I'm afraid of gaining weight or developing hypo, I will not take injections. It's just a rejection within her mind. Is there anything else available? Now from the doctor, he will be thinking, I think she will refuse. Let me not propose insulin at all, because he is also worried that in case if I force this lady, she may change me and go to another doctor, which is very, very possible in India. Even though the doctor knows, as per the guidelines, the patient needs. If you look at the literature, the promoters of therapeutic inertia often cited all these reasons on the clinician side, this is on the patient-related side, and this is on the healthcare system-related side. It's available for all of us to read. And probably each one of you who are listening to this will add a few more points also. Either it could be clinician-related or patient-related or healthcare-related. We have enough reasons as to why our patients are not under good control. Let's look at the present view. Fine, let's accept there is inertia, both on the doctor side and on the patient side. Although there is therapeutic inertia, although we know it impacts all population, targeting individuals with type 2 diabetes should be our first priority. If you have accepted to be a doctor treating people with diabetes, please accept this. The causes of inertia are multifactorial, with contribution coming from different stakeholders. It can come from people with diabetes who are patients. It can come from clinicians and other healthcare providers. It can come from the healthcare system itself and the payers, which is basically the insurance group, and of course the industry. Well, you can have a workshop itself, which lasts for about 6 to 8 hours, talking about the various things coming from each of these groups. First, as a doctor, if I have to cut off the inertia, I think we must learn to use the algorithm and follow the guidelines. It's very easy, especially with oral hypoglycemic agent usage and insulin usage. We have the guidelines. We can sit with the guidelines. I'm just showing an ADA guidelines, but I'm sure RSSDI guidelines is very similar to this. We need to sit with the guidelines. Maybe if we have time, or if we can make time, or if your nurse educator can be taught, they can even show the guidelines to set of patients. It's very clear what to start, what not to start. And most importantly, we need to spend time. Now, this is what is missing in India. And that's the main reason, because writing a prescription is going to take us just 1 to 2 minutes. The moment you look at the values, you've already decided what you need to do. Because you need to spend a lot of time on dietary counseling. If somebody is overweight, you need to talk about the weight there. You need to talk about the exercises suitable to that particular patient. And a huge psychological counseling is necessary. So the counselors are becoming a part of your diabetes care team today, and you can't do away with them. And whatever prescription you give, however brilliant you are as a doctor, you are only doing 30% of the job. The 70% about diet, exercise, medication, and keeping the mind in the right frame of things goes to the patient, and you have to prepare the patient. We need to utilize the technology as much as possible. Use it to lessen the burden of diabetes, not to increase the cost, and to increase the patient engagement and probably outcomes. Just because there is a CGMS, it does not mean you can use it. You use it in the right patient. Insulin delivery devices, just because the company says that it's easy and dosing is better, talk to your patient. See whether they can learn how to use a syringe, because you're reducing the cost. And these are the usual things coming to the technology. Well, you don't need to know all the options, but be familiar enough with one to have a resource. And most important, this is something that all of us who are seeing patients with diabetes must do, is to have electronic health record and use of artificial intelligence in our practice. Can be as simple as a slice and dice. For example, once or twice a year, you generate a letter to all those with HbA1c more than 9 who have not been seen in the last 1 year. Our review numbers are coming down. It used to be once in 2 to 3 months, but nowadays, because of the COVID, it's become 6 to 7 months. So this is where this becomes useful. Very useful for data management and self-audit to know how your patients are doing. Research interest definitely with the electronic record system will help us to reduce inertia, because you're constantly watching how you are doing, how your patient is doing. And of course, artificial intelligence is a very useful tool in diagnosis and grading of DR, and hopefully in future, probably the clustering of diabetes and in diagnosis, and probably use of the right medication can be extremely useful when AI is used. Most important, if you want to reduce inertia, it's all in the follow-up. Please establish the next appointment during the current visit. Agree upon the action plan to be reviewed at the next appointment. Advise your patient to keep pace with their disease. You can always have a phone call follow-up or an SMS, WhatsApp, email. Constantly, if you are in touch with your patient, that's one way of improving the quality of care, and probably the inertia will come down. Let's show the right path. This is the right path in which the patient has to go. Well, the path can be very smooth, or we tell the patients the path can also have some obstructions. This is like a rumble strip here. This is a hump. This is a road with a lot of potholes. I and you cannot change the path of the patient. It's the destiny. All that I and you can do is to tell them how to navigate through bad roads, how to navigate through good roads, how to wear the right footwear, and how to manage obstacles. And this is where we are going to score. And importantly, remove the thought that says it's difficult, because no person with diabetes should feel it is difficult to manage diabetes, because all barriers can be crossed. And what is the problem with the barriers? It's basically the thoughts in the minds of the people with diabetes. And once they have the wrong thoughts, the feeling that the thought generates creates a behavior. And this can be either a positive behavior or a negative behavior. And most often it's always a negative behavior. And once you have a negative behavior, it reinforces the thoughts again. And it's a vicious cycle. So we have to talk to our patients about positive thinking. And how do you break the barriers? It's only through counseling patients. And this needs time. And when once you have the time, you have broken that inertia. Or your care team will have a counselor. Teach the patient to accept, adopt, and adjust, because nothing else can be done. You are what you are today. You can't go back to the past. You can't change your parents. That's what I tell my patients. Well, let's accept what you are today, because you're going to live long, and then you adopt and then you adjust. And you have to focus only on positive thinking. We have to tell them there's a huge difference between hope versus reality. It's a good example of positive thinking. When you can't change the direction of the wind, adjust the sails. And for all of us in day-to-day life, I think this should be the dictum. You can't change what's going to happen tomorrow, but we can adjust the mind to accept what is likely to happen and move along in life. And as most of the guidelines say, it's going to be a shared responsibility between the doctor and the patient. So we must avoid clinical inertia. So you should have a better follow-up of your patients. Call them regularly, once or at least once in 6 months. Again, it's a shared responsibility. Tell the patient that you have to come back. Diabetes care is a teamwork. It's comprehensive care, and it's going to be lifelong. And clinical inertia can be overcome not just through knowledge, but a number of things. Knowledge and training, patient-centric approach, building a strong diabetes care team, strong patient education, patience and compassion towards the patient care, use of technology and artificial intelligence, psychological support to the patient, research which is much needed. Right knowledge is the ultimate solution, and choosing the right over pleasant is something that we all have to practice. So the possible solution. So before I close, most importantly, it's a shared responsibility. Use multifactorial approach for care to cover all aspects through complex and complementary organization, educational and training strategies. Continuous CMEs to upgrade the knowledge, follow guidelines which are evidence-based, creation of multi-professional teams to work with a common and a shared language, continuous educational activity to improve patient self-management abilities and responsibilities, and a strong diabetes care team, including counselor, in seeing all our patients. This is my last thank you slide. This is from Larry King, a wonderful saying. I remind myself every morning, nothing I say this day will teach me anything. So if I'm going to learn, I must do it by listening. To all those who listened and got bored, thank you so very much, and sorry.